as you have mentioned in your article, cholangiocarcinoma, the best treatment may be the surgery. So surgery is the most reliable treatment. But if it is not possible to resect, I think chemotherapy is the choice. So I appreciate your article. And my question is that you have mentioned about the adjuvant chemotherapy. So I think adjuvant chemotherapy may benefit for the patient. So I'd like to ask, what is the indication of adjuvant chemotherapy for cholangiocarcinoma? So is there any criteria for including chemotherapy for the patient? Professor Colombo, Massimo Colombo.
Okay, thank you very much for your question. In my article, I try to review the state of the art. And as far as I understand, because very frankly, I'm a clinical hepatologist mostly engaged with diagnosis and screening of this patient, then Professor Cascino is the master and commander when it comes to chemotherapy. From what I can understand as a, clinician that is broadly engaged with liver diseases, is that the introduction of new adjuvant therapy has helped survival figures for patients undergoing hepatic resection for proximal cholangiocarcinoma. I had a chance to review the data that have been Eaton and Professor Murad. Recently, I have attended a very nice webinar that was generated in London just last week. And I tell you that those figures are rather convincing. As you know, there is a big argument going forward between within your community of surgeons between liver transplantation and resection for proximal cholangiocarcinoma. The transplantation being obviously limited by the demand of organs. We are running short of donated organs, and the risk of a recurrence caused by immune suppression due to faulty staging. So if I may, I would love to pass the word to the real expert in the field, which is Professor Stefano Cascino, who is the chairman of clinical oncology in at the San Rafael Hospital, where I act as a pathologist. And perhaps we can come back with some interaction between us when it comes to diagnosis, because what I really understood from this very interesting literature that is available is that the outcome, for instance, of liver transplantation is perfect for those cases that are connected with primary sclerosing cholangitis. And I understand why, because it is a matter of early diagnosis and treating the patient in an early stage, favorably early stage, versus the other causes. And I'm very much interested in understanding in your geographical areas what the connections are between primary sclerosing cholangitis and risk of cholangiocarcinoma. So I'm very happy to leave the stage to Professor Cascino, and I sit here learning from him. Thank you so much for your question, anyhow.
No, I'd like to thank again for this invitation, and I really thank Professor Han, because I think that there is no doubt that probably surgery continue to be is the cornerstone of treatment in cholangiocarcinoma. I think there is no matter of concerns about this. The question is probably that most of these patients relapse or have the risk of a recurrence in a short time, really not after years, but even after some months. And this may be the consequence of a multifocality of this tumor. For instance, sometimes there is this risk, and most may be due even to the biology. And at least the disappointing result for medical oncologists is that there is no clear evidence that a chemotherapeutic regimen may be considered the standard of treatment. Of course, I know that probably capecitabine may play a role in this patient, but if you look at the results, we can reduce the risk of death for some of these patients, but the really advantage is not so huge. Otherwise, if you have an intensified treatment, such as, for instance, gemcitabine and oxaliplatin, the French trials were not able to demonstrate any benefit for this patient. So I think it's really frustrating tumors, because we know that we need a systemic treatment after radical resection, but we don't have a specific regimen able to improve really, like, for instance, in colorectal cancer. And probably the question is, which kind of patient could be good candidate to receive an adjuvant treatment? I think that probably patient with a positive lymph nodes for intrahepatic cholangiocarcinoma, and probably patient with a positive surgical margins. I think that probably this patient population may really benefit of a systemic treatment. And finally, probably we have to consider that while chemoradiation therapy probably doesn't play any role in intrahepatic cholangiocarcinoma, this is my personal opinion. I would like to know your opinion about this. I think that for extrahepatic cholangiocarcinoma and for gallbladder carcinoma, probably the adjuvant treatment could be considered even a combination of chemotherapy and radiation therapy, because most of the recurrences are local relapses and not distant relapses. And sometimes there is no way to control this disease in the local situation. And so I think that we have to consider separately. I know that it happens commonly, but intrahepatic cholangiocarcinoma and extrahepatic and gallbladder carcinoma probably may be considered for different treatment adjuvant approaches. I don't know if you agree with this situation. And finally, the regimen in Italy, we use capecitabine based on the Britain trials. But I think that sometimes where there is a and several positive lymph nodes, probably we use even gemcitabine and oxaliplatin. And we are aware that there is not a positive result from this trial, but sometimes this patient may be considered with advanced disease, not an adjuvant treatment. And so this is why we consider sometimes for a more aggressive chemotherapeutic regimen, even if there is no clear evidence that there is a benefit for them.